I'm Dr. Nitsana Spigland. I'm the Chief of Pediatric Surgery at the New York Presbyterian Hospital Weill Cornell Medical Center. I specialize in neonatal, pediatric, and adolescent surgery from newborns to age 21. I have a particular interest in antenatal counseling and newborn congenital malformations, as well as pediatric surgical oncology and pediatric thoracic surgery. I've been a practicing pediatric surgeon for 19 years. I did my pediatric surgical fellowship at the Saint-Justine Children's Hospital in Montreal. I then spent some time at UMD&J Robert Wood Johnson in New Brunswick prior to coming to New York Presbyterian Hospital Cornell Medical Center in 1995. The advantages of minimally invasive surgery are that the patients recuperate faster, they're able to get out of the hospital faster, they have smaller scars, and they have a lower incidence of complications such as intestinal obstructions down the line. This is especially important in children who basically have the rest of their lives to live, hopefully without further surgeries. I perform many of the neonatal congenital malformations such as diaphragmatic hernia, esophageal atresia, intestinal small bowel atresias, omphalocele, gastroschisis, lung malformations. These are all under the realm of congenital malformations for children. I also perform the routine appendectomies and hernias on older children, as well as tumor surgery and thoracic surgery on older children. We perform minimal access techniques for a number of pediatric surgical conditions. We place very small drains in little babies with perforated necrotizing enterocolitis. We perform video thoracoscopic approaches for the resection of various lung malformations, and we perform novel techniques for bridging the gaps of the esophagus together for babies born with esophageal atresia, tracheoesophageal fistula. The advantages of children having surgery at the New York Presbyterian Weill Cornell Medical Center are that we offer a multidisciplinary approach. This begins with our obstetrical colleagues who identify the malformations antenatally while the baby is still in the womb, in utero, and I often meet with the families and the parents and perform antenatal counseling. I'm then available when the babies are born, and should the babies need a surgical intervention, we coordinate the care with our neonatal colleagues. As such, we have a combined multidisciplinary approach towards the treatment of these complex malformations.